Welcome everyone to today's webinar. I am Megan Knowles with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in a space labeled Enter a Question for Staff and clicking Send. We're looking forward to hearing your questions. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar preparation of materials can take some time. It is now my pleasure to introduce today's presenters. Barbara Sharpless is the Director of Physician Services for Baycare Medical Group, part of Baycare Health System in West Central Florida. Barbara has over 20 years of experience in physician practice management, including physician recruitment and contracting, physician onboarding, network development, physician practice operations, and physician compensation. She has worked with employed physician models in both nonprofit and for-profit health systems. Michael Anderson is Vice President of Human Resources for the Physician Services Division of University of Pittsburgh Medical Center. UPMC is one of the nation's largest integrated healthcare delivery systems, with over 30 hospitals and 80,000 employees. The Physician Services Division encompasses 2,800 physicians and 1,700 resident and fellow physicians. Michael also has had HR leadership roles in UPMC's International and Commercial Services Division and UPMC Cancer Center. At this time, I'm pleased to turn the floor over to Brian Warren, Director of Healthcare Solutions at Select International, to begin today's presentation.
Thanks, Megan, and I want to thank Becker's again for sponsoring our webinar and thank our speakers, Barbara and Michael. We're looking forward to an engaging discussion as always. As Megan said, please feel free to submit questions throughout the discussion and we will incorporate them where they make sense. We want this to be an interactive discussion, so I'm going to have some introductory material on the front end. Barbara's going to tell us about some of the work they're doing specifically at Baycare Medical Group. We'll work Mike in and then we'll have a Q&A at the end, which will be the bulk of the discussion. So I'm going to talk a little bit about how the physician's world continues to evolve, how the system, the healthcare system generally and health systems are imposing new expectations on physicians, what systems and hospitals are looking for and expecting from physicians, some of the challenges they face that impact their performance and career satisfaction. Then we'll talk about some innovative solutions and ideas. We'll talk specifically about the work that we're doing at Select with some of our clients in the area of physician hiring and development. We're going to hear from Barbara about how they're addressing some of these challenges at Baycare Medical Group, especially how they've integrated some of these concepts into the hiring process. We're going to pull Michael in to talk more about what they're doing at UPMC to help physicians succeed once they're on board, they're with the organization, helping them grow and develop their behavioral and leadership skills. And again, please feel free to submit questions throughout. The team at Select has worked on hiring and development projects with companies like Toyota and GE and Goodyear for decades. And over the past 8 years or so, we've built a team focused on healthcare, as you can imagine, with all the changes that are going on in our industry and all the tools and challenges that come into play. But in the last few years, a lot of that work has been around physicians because many of our clients have asked us to apply similar tools and concepts and expertise to help position physicians for success. So we've done things like add objectivity and structure to evaluating fellowship candidates. We've been involved in some resident selection processes. We've brought executive hiring interview techniques to the physician hiring process. Again, thinking about physicians as executives and trying to have a physician interview that actually gleans useful information as well as creating a positive candidate experience. We've added physician-specific behavioral assessments to the hiring process, and Barbara's going to talk about how they do that at Baycare Medical Group. We've added structure and tools to the hiring process for senior leadership roles, so department chairs and CMOs. And as you can imagine, a lot of this has led to a variety of physician leader training sessions focused on key behavioral skills. In fact, we've worked with Mike at UPMC to work with physician leaders from various countries that come to UPMC to learn about some of these topics. And this work really grows out of all the changes that are taking place and the fact that organizations and physicians are really looking for new solutions. In the past few years, actually probably over the past decade, the business of medicine has undergone drastic changes, as we all know. The nature of the physician-hospital relationship has changed significantly. Far fewer physicians in independent practice, and turnover is increasing, and we'll talk about that. This world is changing, and we've not historically applied a great deal of structure and sophisticated tools to helping physicians to succeed, but organizations like Baycare Medical Group and UPMC are starting to do that, and that's what we want to talk about today. The role of physician leaders continues to evolve, and we can talk about that, but how we choose physician leaders, what the expectations are drastically different. Some physicians are struggling to balance the concept of the traditional professional sense of autonomy with employment and with new integrated care delivery models. They challenge the sense of professional autonomy of physicians, so you've got to find a way to balance that. In addition, physicians are adapting, obviously, to quality-based payment systems, and these sorts of changes all place an emphasis on behavioral skills that weren't a focus of physicians traditionally. So behavioral skills like emotional intelligence and collaboration, and certainly business acumen. We're asking physicians, even if they're not in a leadership role, to have a level of business acumen and make decisions that are certainly in the patient's best interest, but have to take into consideration the financial realities of our healthcare system. As you talk to younger physicians, especially, you also pick up a disconnect, perhaps, between training and practice. The practice of medicine today requires more team-based care, an understanding of social determinants of health, and some other skills that aren't necessarily emphasized in traditional training. So we can talk about that. Turnover continues to be a problem. Physician turnover is starting to push 7 or 8% in some markets, and certainly that's not the 17, 20% that we see in nursing or other areas of healthcare systems. But physician turnover is incredibly expensive. The actual finances of it are expensive, but the impact on the organization is significant. So when you start to see that level of turnover, it creates a problem, and we need to understand the causes. And what we see frequently is turnover is highest in the first few years on a new job. And often that's not because of finances, it's not because of pay, it's not because physicians are seeking higher pay. More often than not, the data shows that it's because of a mismatch of expectations or poor cultural fit, and we can address that. That's something that honestly shouldn't happen that often if we do the work that we're supposed to do and bring some structure and diligence to the hiring process. And when we think about physician leaders, and I'm going to get some of Michael's perspective on this because I know he participates in some of the leadership development efforts at UPMC, drastically different physician leadership expectations and roles. New titles, Chief Medical Information Officer didn't exist 10 years ago. So we're not only creating new leadership roles, but even the physicians that are in those roles, we're asking them to do more. We worked with an academic medical center a while back, and the CMO said he has tasked each of the department chairs to act as the CEO of their own department. When we interviewed each of those physicians, they weren't quite sure what that meant. They weren't quite sure they were equipped to do it, and we had to bring some structure to that so that they could feel like they were positioned for success. So the traditional criteria for selecting physician leaders don't really apply anymore. The idea of being an outstanding clinician and researcher and having done some committee work, that would position you for success in leadership as we view it today, it's probably not realistic. So we're asking them to lead very complex organizations, and what we chose these leaders for in the past simply is not going to work. These physician leaders need to motivate, they need to communicate, they need to manage conflict, and again, have a really high level of business acumen. So we've got to think about it differently. And I think everybody realizes that. We've seen it, we understand it. Intellectually, we grasp it. The challenge is, how do we apply some of the structures that we would use in human resources, talent development, organizational development? How do we apply those to physicians? A lot of the concepts are the same, but the context is different. What physicians bring to these situations is different. So it's got to be a little different. So we think about focusing on selection and development. How can we actually improve the hiring process to predict success and position physicians for success? How do you add physicians whose goals are aligned with the vision and culture of the system? and certainly how do you ensure physician success and satisfaction. Those are what we're trying to accomplish. And we're going to talk a little bit, particularly Barbara's going to talk about some tools they're using to understand physician behavioral skills, but I want to give some context to this. We would never argue that any particular tool is the tool to help you choose the right physician for your organization or develop them and identify their strengths and their gaps. What we want to think about is a pretty holistic approach. In that respect, for any position, but particularly with physicians, we want to think about the concepts of measuring individual potential. So whether it's physicians, executives, nurses, or other frontline staff, our particular area of expertise is looking at personality data, and Barbara's going to show you again how they use some of this data. But when you have it, historical performance data is valuable, incredibly valuable, and then you have perception data, how an individual is perceived by peers, colleagues, supervisors, and subordinates. If you imagine a hiring scenario, if you can put those three components together, past performance, perception data, and personality and behavioral data, you can make an informed, objective decision. The same thing is true with identifying people for leadership roles. And for those of us on the call who work in the HR talent space, we get this. This is how we evaluate executives. This is how we evaluate frontline staff. It's a structured approach. We pull the data. No particular piece of data is determinative, but we want it to be as objective as possible. What we found is, not surprisingly, we can apply these same concepts to physicians. Again, the context is a little different. What physicians are trying to accomplish is a little different, but the concepts, they work. And here are some of the things we've learned. I can tell you that 5 or 6 years ago, we started talking to clients about the idea that many of them were building out an employed physician network. They were creating what we referred to at the time a new physician workforce. It didn't exist before. You know, physicians existed in smaller private practices and didn't think or function like employees, but now they are. They're in that role. They're employed. They're employees of the organization. You know, they're your resource, an incredibly valuable resource, but they're your resource to manage and make them successful. So the challenge became, how do you apply some of these concepts to physicians? And there was resistance to this. There was a lot of thought that physicians wouldn't respond well to these tools, that these tools and concepts wouldn't work with physicians. But we know they do. So here's what we've learned. First thing is that the pressures and challenges are driving a demand for solutions. 5 years ago, I talked to organizations who would say these concepts are interesting when it comes to physicians and something they wanted to consider. I can tell you now, the phone calls are more, we need a solution, we need to do something differently, we need to solve this problem, we need to make physicians successful, we need to avoid burnout, we need to reduce turnover, we need to position physicians for success, so how do we do it? So the pressure's there. Physicians respond well to this if they see that the results are linked to the organizational performance and their own performance. So for instance, I had a discussion with a physician board member several years ago who said he was at a retreat. They administered an emotional intelligence assessment. It was a fairly generic EQ assessment. He took the test and he was told, well, you scored low in emotional intelligence. And his comment to me was, what do I do with that information? It's not in context. It doesn't give me any guidance. So we've got to see how these sorts of results and these tools link to organizational and individual performance. And the tools have to be meaningful for physicians. You can't take your nurse hiring process and superimpose it on your physician hiring process, certainly. So the tools and the processes have to be specific to physicians and meaningful. We have found that candidates in the hiring process have responded quite well to this. The handful of clients that we have that are using, for instance, a physician-specific personality assessment in the hiring process, there was angst, there was trepidation. Recruiters were a little nervous about this, but I know Barbara will tell you that the vast majority of candidates go through the process willingly and find it to be a positive experience. We've not seen a great deal of resistance at all. The information gleaned is particularly useful. I know Barbara's told us some great stories at Baycare Medical Group of how they've used this information, not just to decide whether someone was a cultural fit for the organization, but how they would choose the right role for them. So that becomes important. And we have seen, and I don't think this is a surprise to any of us, that physician leaders need the same traits as leaders in other fields. We're looking at the same skill set. It's just a matter of the context. So that becomes a little different. And I'll just show you one example. I referred to this earlier. Chief Medical Officer called and said, I know you do a lot of executive assessment in a lot of industries. I've asked my department chairs to run their department as a CEO. Of course, that means a great deal. That means you've got to lead, you've got to motivate, you've got to think strategically, you've got to deal with the finances of the department. And we started by putting everybody through essentially an executive assessment process that we would use in any other industry. And we identified very quickly that as a group, they scored low in attributes that were required for success. For instance, this group scores low in holding others accountable, some of the relationship skills, planning and organizing, and individual accountability. Well, if you're asking this person to function as the CEO of their department, they're going to need those skills. And not shockingly, there were some operational challenges we saw at the organization that related directly back to this. So out of this information, we were able to put processes and tools and resources in place to support the physicians for success. So that's just an example of the way you can use some of this data and these tools to bring resources to physicians so that they can be successful in these roles. And to give you a sense of this, I'll just give you a quick snapshot of two of the tools that we use with physicians. This is a tool we use, and again, this is the personality behavioral trait assessment. This is select assessment for physician leaders. It measures 18 really important competencies. Again, it's not measuring behavior. If you wanted to get true behavior, you might get past performance data and perception data, but this is a critical component of behavioral traits. Someone who consistently scores low in areas like initiative, openness to new ideas, managing change, they're likely to struggle in that. So that's a data point that becomes important if you're positioning a physician in a leadership role or if it's for development. And then we have a shorter tool, and this is similar to what Barbara is using at Baycare Medical Group during the hiring process. This takes 30 minutes. It measures some interpersonal style, thinking style, work style, and just hits managing change. And these are just examples. We have other tools. We can customize them. But these are the sorts of tools we're trying to bring to this process to allow Michael and Barbara and our other clients to have more objective data, both for hiring and for developing physicians and positioning them for success. So I'm gonna hand it off to Barbara now. I'm gonna let her tell you a little bit about Baycare Medical Group and its role within the Baycare Health System, and then some of the challenges that they deal with, and when they first reached out to us about this project, what they were trying to accomplish, and then we can go from there. Barbara?
Hello, and I want to thank Brian and Becker for inviting me to join you today. Little bit about Baycare Medical Group. We're in the Tampa Bay area, about 4 counties, and we have over 600 providers, multi-specialty, just under 200 different locations across those 4 counties. We are part of Baycare Health System, which is a 15-hospital system, as well as, of course, ambulatory centers also across those counties. So pretty widespread geographic area, but in some respects, but of course very localized in other respects. We are not-for-profit, so we have all the advantages or disadvantages of being not-for-profit, depending on how you look at it. Some of the things that we were looking at when we decided to go through with doing some type of assessment, and I'm sure most of you probably face these same things, we had fewer candidates and more competition for those candidates, and we had a lot of openings, particularly in primary care. We also found that we were bringing in candidates, but there was no depth to the interview process. So it was essentially, hey, did that 5-minute meeting result in a positive experience or a negative experience? And that was the basis of whether or not we made an offer. So it was very sketchy. And given that the competition, even in Florida, was getting tighter, we weren't getting the candidates that we wanted, and we certainly didn't feel like we were getting the quality that we wanted. So we looked at trying to find a tool that would give us a little bit more depth to this process and determine whether or not, first of all, was this a candidate that was going to fit within our culture. So when we started working with Brian and Select on this assessment, one of the first things they did is, okay, what are the things that you're looking for? And being part of a health system with a lot of red tape, policies, procedures, we needed to make sure that while we valued somewhat of an entrepreneurial nature for our physicians, we also wanted to make sure they weren't going to be so frustrated by all the rules and processes that they have to live with that they were just going to come and leave within a year. So those were some of the goals that we wanted to achieve with this tool. Some of our concerns up front, and I think Brian mentioned some of those, were the physicians going to be receptive to this tool? And were we going to get out of it what we expected? As far as the reception on the physicians, we've not had any pushback. Now, one of the mistakes that we did make early on is we were so excited about this that we said, we're going to give all of our medical directors that were currently in place this tool so that they can experience it and see it and support it. Well, we gave them the leadership tool, which was the 90-minute assessment. Okay, so that was not a good idea because it kind of set a bad taste in their mouth. They're like, well, nobody's going to take this. And we kept saying, no, this is not the one that candidates are going to take, but they didn't believe us. So we had to kind of refocus them a little bit and had them take, because some of them didn't even finish the 90-minute, we had them take the shorter 15, 20-minute assessment that we were given to the candidates, and it was much more favorably received. Part of this process was how to teach the physicians, not only our medical directors that are involved in the recruitment process, but the physicians at each site who are not medical directors, they're just practicing physicians, how to use this tool constructively and not look at it and say, oh, they scored low, so I don't even want to see that person. So we were also very selective in who had access to the tool. We've now expanded that because as we've been using it and our medical directors are used to it and our recruiters are used to it, we've been able to spread it out a little bit more and use it a little bit more broadly across the group when we're bringing in site visits. But one of the things that we did find right up front is that it gave us the ability just from the get-go to ask more in-depth questions. So even though they might score low in an area that we think is really important, it doesn't mean that they're not going to be a fit for the group. It just gave us good questions to ask. And the other thing that we found is that depending on the situation the physician is in when they're taking the assessment, that can drive what their scores come out to be. So if they're in the middle of, of really heavy rotation and they've got a lot of family issues going on and they're very stressed and they're running around the country interviewing everywhere, they could score very low. But then when you come and interview them and you're asking questions, their response to the questions tend to be exactly what you want to hear. And they're not questions that you can fake, so to speak. So it really gave us much more depth. And it also, for the physicians that were at the site who did the 5-minute, hey, how you doing? Do you have a family? Or, those kinds of very surface questions, it gave them something to ask so that they felt at the end of the site visit that they really got to know that physician much better than that quick 5 or 10 minutes or even a lunch, because all you're really talking about is chit chat instead of really getting into some depth. So those were some of the things that we found right up front that we considered very positive and very well worth using the tool for. What's changed with the physician interview? Oh, did I skip? I probably skipped the slide.
It's okay.
And I think I went through some of these already. We do feel that the physicians are more engaged in the site visit, the physicians at the practice and the medical director. And one of the things that, in particular with our specialists, that we found is that while the hospital presidents were always involved in the specialty recruitment, once they found out this tool was out there, they started asking for it, and they wanted to see it before the physician came. And they were very specific about that because it gave them better questions to ask. And many times they're in a better position to determine the cultural fit for specialists because it's so dependent on the politics of the medical staff, which they're much closer to than we are. Let's see. So how do we use the assessment? We give it to every single candidate that we are planning to bring in for a site visit. We try to get it before they come in for the site visit. If we can't get them to do that for whatever reason, we ask them to take it while they're here. And we can usually get pretty quick feedback and turnaround on that. So I think the majority of them do fill it out beforehand, but some of them do fill it out on site. And even if we don't have it during the site visit, when we're determining whether or not we want to make an offer, we do look at it. And in some cases, if they've gone to like 2 or 3 different sites, we might look at that to say, all right, they liked every site, or that we had good feedback from everyone at each of those sites, but maybe one is a brand new site and one is a well-established site. We look at their profile and say, would they fit better at one or the other? And use that in some cases as potentially a determining factor, not exclusively, because a lot of times the physician has some preference, but if they don't, we do look at that.
Hey, Barbara, can I jump in for a second?
Sure.
Yeah, I had a question. So, and maybe in a comment, I might pull Mike into this. So you've mentioned the interview a couple times. One of the things we've done with some other clients, I think we did a little bit with you, but not quite as much rigor or detail, is actually start to build out a structured behavioral interview guide for physicians. So we've had questions about that, and we've done some work. And obviously, you can't interview a physician as you would a nurse. You can't use direct interviewing questions because historically it's been more of a physician-to-physician dialogue. And someone asked the question, actually, do you target the interview questions based on the assessment or ask a universal set of questions? What we've done is identify the competencies that are most important for the organization and build an interview guide, and then train physicians on how to use that interview guide. And again, it's more of an executive interview, but it does start to incorporate structured behavioral interviewing concepts into a physician-to-physician dialogue that's not stilted or uncomfortable. So that's what we've done. I know, Mike, UPMC did some research a few years ago on a physician interview that was actually useful in predicting disruptive behavior. So I don't know if Mike, let's use this opportunity to pull you in. What are you guys doing on the physician interview? How have you tried to evaluate culture fit or organizational fit during the interview?
Thanks, Brian. We focus a lot more on the behavioral interview guides as opposed to assessments, but we have used assessments in the past. And to answer the question that I think someone posed there, generally we do use standard guides for our physician interviews, and then we'll look at assessment results and try to find some of those areas of opportunity, as we call them, or some of the lower scoring areas, and just try to poke around a little bit and try to understand experiences in those areas. So generally the process will be fairly standardized, but it may be a little bit different for each applicant based upon how their assessment data has come across in the past. As you suggest, I don't think it's appropriate, at least it hasn't been appropriate for us to sit there with an interview guide and ask these standard questions, but I think there is a little bit of an art to, having the areas that you really want to probe into and just have that in more of a very conversational way so that you can ask questions about, maybe strategic quality initiatives or how do they deal with problem physicians. And you're really focusing again on some of those behaviors and the overall philosophy behind it is trying to understand how they've done it in the past, assuming that some of that past behavior predicts some of their future performance.
And I think that's a great point because all you're doing really is applying the basic concept of structured behavioral interviewing, which probably everybody on the phone is familiar with, to a physician dialogue. So the questions are structured a little differently, and you can work them into a discussion that doesn't feel, again, stilted or like a traditional interview sitting across the desk, but you can glean really useful information. And I think the the research you guys did out of part of the organization on questions that were predictive of disruptive behavior show that just like interviewing generally, there's a science and an art to it, and it's predictive. Barbara, there was a question about what I'm going to call validation, which is, do we have data on improvements in HCAHPS scores, outcome data, or profitability? And I'm going to give a general question, and Barbara, maybe you can tell me how you want to approach this, because we just had this discussion. Is assessing physicians, applying these tools, is still relatively new. So nobody has a really sound, large set of data to do much in the way of validation yet. We've tested probably 200 physicians as part of the BayCare project. In total, we've probably tested 700 or so physicians right now, but across different situations and with different assessment tools. I know that there's a group called J3P, which does a lot of resident testing, and they've done a really nice job publishing validation evidence, looking at resident performance and personality assessments. Now, they were using a fairly standard personality assessment, not a physician-specific assessment, but we know that these tools, if they're structured appropriately and administered appropriately, are going to be predictive of performance in some regard. The most immediate validation study we would do is, and Barbara, we're going to probably do this shortly, is actually go look at supervisor ratings of performance on the job and how does it correlate. Making the leap to HCAHPS scores and profitability, that's a way more complicated research project. But I think in the short term, I know, Barbara, there's some things you'd like to measure so that we can go back to the organization and say, yes, these tools are useful to us.
Yeah, I think one of the things that we're now we've been doing it long enough that we can now see some things is could these be a predictor of turnover? So I think that's one of the things that we wanted to look at is of the assessments that we've given, who has now left the group and why, and can we tie anything back to, the assessment? And, an easy, example that I used, which I don't think it's that easy, but, if one of their assessment said something about they are more entrepreneurial versus wanting to follow the rules, and our experience with them was they just got very frustrated because, they kept getting blocked by our policies and procedures and those types of things, and they couldn't do all these fancy new things that they wanted to do, and they end up leaving. Is that something that when we look back, should we have known, could we have predicted, and should we have done a better job during the interview process to probe that more? So those are some of the things that we're looking at to see if we can predict turnover, because, as you know, turnover is really awful, especially with primary care physicians.
Yeah, and our plan, and again, we do this in lots of industries, we do it with executives, is we're going to take that data shortly. We're going to look at those who have left, and we're going to probably see some trends. We're going to see, as you said, that those who score really high on the entrepreneurial scale are going to struggle with change, or more directly, someone who scores low in managing change. So we're going to do that work. I think there's going to be some useful data there. I think it's going to be consistent with the data that's already out there. Again, there are about a half a dozen really good validation studies that have already been published. But to Barbara, to your point, it was really good, it is a data point. The behavioral traits from an assessment, like Mike said, are a piece of the puzzle. I always use the example, I score low in attention to detail. I always will, but part of my job requires some attention to detail, and I've developed abilities over the years to compensate for that behavioral trait. But to Mike's point, boy, if you have that data, you can then focus on it in the interview and confirm whether that person has that ability there. And you mentioned turnover, and I know Mike has some thoughts on turnover. I'd like to hear, Mike, how the physician services group at UPMC is thinking about turnover and maybe trying to prevent it.
Mm-hmm. So our focus on turnover right now, Brian, is more related to physician burnout, or as we call it, physician wellness. There are a lot of changes going on at UPMC. I mean, we're a very large organization. I know that as part of the introduction, Megan had explained we have about 80,000 employees. We're a $16 billion organization, and I'll skip most of the details. We have about 5,000 employees. We've been expanding very, very rapidly We are the #1 provider and insurer in Western Pennsylvania, but have moved into this through acquisitions, rapid acquisitions through the center of Pennsylvania, and are in discussions as east in Pennsylvania as far as Philadelphia. So UPMC moves very, very quickly for a large organization. And just with the changes in healthcare, I'm sure that everybody on the phone, your organizations are dealing with the same things, which are really our physicians now are team leaders as opposed to doers in a lot of cases, and we're really asking them to manage teams of advanced practice providers. We're talking with them at every turn about managing quality and changes with bundles and pathways, and we're putting in new EMR alerts that are popping up everywhere that make their lives a little more complicated. And we also have a focus right now on consumerism, because there really is a lot of competition in healthcare in Western Pennsylvania and across Pennsylvania. And so we recently rolled out same-day access, for example. So if you call by noon, you'll be seen by a provider that day. And that's very difficult on the schedules of some physicians that maybe in the past have not opened up their schedules for essential scheduling mechanism. And obviously patient satisfaction focus, and it's again they're losing control sort of at every place. So our focus has been on physician wellness and burnout, and we're starting off here. We actually are going to push a survey. We've joined a consortium with Stanford University, and we're pushing a physician wellness and burnout survey here in the fall, and our hope is just to really understand what are some of the drivers of physician burnout, which then of course leads to physician turnover, and then of course a variety of behavioral issues that we deal with on a daily basis that are outbursts by physicians, outward displays of anger, all the way through drug and alcohol abuse, to family issues, to addiction issues, to legal issues, to unfortunately physician suicides. And so sometimes it's bigger than just physician turnover. But again, we're really trying to do a survey to understand this a little bit, and we've also had a number of symposiums where we have both internal and external speakers, and we're really working with all of our chairs and chiefs and physician leaders, medical directors, et cetera, to have every department have sort of, quote, an owner of physician wellness within each department. And we can push a variety of initiatives out to them, and it's sort of plug and play within all of the departments. So that's really where our focus has been. We are trying to transition over from a lot of physician care to advanced practice provider model. So some physician turnover for us, if it's the right physicians, isn't a big deal, but we certainly don't want to drive away our physicians with some of these initiatives, and we certainly don't want to have burned out physicians as well.
It's interesting. There are a lot of things we could talk about, but there was a question that came up that I want to work in. And the question was about, in addition to a behavioral assessment, do you explore physician candidate expectations in their role? And one of the things I've noticed is we've built a new workforce, but as Mike alluded to, we're just starting to build the infrastructure to support that workforce. And I would say 5 years ago, we all talked a lot about physician disruptive behavior. Now we're talking about burnout. And getting back to the question, I've always found in doing some operational alignment work that what we would frequently refer to as disruptive behavior was really just frustration that was manifesting itself in certain behaviors. And the frustration was because we didn't do a really good job aligning expectations on the front end. I alluded to the cause of turnover, and the studies frequently show that it's a misalignment of expectations. So it's important on the front end to not only understand who the physician is individually and their behaviors and their strengths and their past performance, but giving them a really solid understanding of what the expectation is in the role. We've done some projects where we actually built a custom operational fit survey, where we would say to a surgical candidate, what sort of surgical volume do you anticipate? How much time do you like to spend in the office? How much time do you like to spend on research? What is your interest in quality-focused initiatives or leadership? Because we're going to be asking that of you. And if a candidate's alignment is not particularly good, then we need to go into that situation carefully. We've got to get beyond Mike's an orthopedic surgeon, I need an orthopedic surgeon, I'm going to do everything I can to get a contract signed. because I think when you do that, you lead to frequently disruptive behavior or burnout, because you're creating stresses that the physician can't deal with, isn't equipped to deal with, and you haven't provided the infrastructure to help them deal with it. On a very basic level, Barbara, what do you guys do on the operational fit piece? How do you figure out during the recruiting process that those expectations are aligned or not?
Yeah, that's a good question. And I think, again, the assessment and the interviewing questions that are provided as a result of that have given us, I think, structure around that, because, you know, you can say, here's our expectations, here's what our environment is, but they're not necessarily, I mean, if you're talking to them, they're not necessarily hearing it. What we find is by using the questions, we can then ask them questions, get their thoughts, and then by that interaction, we help them understand what our expectations are and whether there is a disconnect there. So again, I use the entrepreneurial versus rules and regulations kind of spectrum, which is, you know, if when we ask the questions, the physician's responses are, well, I want to do this and I want to do that and I want to go there and how about this? And we're like, well, no, we don't move that fast as an organization. And in order to do that, there's a process and there's this. And it becomes very clear in that dialogue whether or not this physician is going to be a fit in this environment or in that practice. And again, one practice may differ from another, so that, you know, and what we find is by that dialogue, one practice might say, my gosh, this is the perfect person for us and we want that person and it's great. But then another site who maybe asked the same questions, the physicians are like, no, not really a good fit. So, you know, I think there's the broader question of the operational fit and expectations that the organization has that we can address. But then there's the much more finer operational fit that you have at the site level. And I think the tools that we've been able to use as part of this has given us the ability to do both.
I think one of the things I always hear from your group is that, you know, we don't have the perfect solution yet, but the tool that we have in place has added some structure to the process and made people think about it differently. So that's been exciting for us. And I pulled up just so people can get a sense of what we're actually measuring in this tool. And this is one tool. We have a library of tools. We can custom design these tools. This is a little different than the one I showed you earlier, but so people can get a sense of this, we're measuring things like values diversity. Are they results driven? Do they have leadership potential? Are they customer focused or service oriented? So these are the sorts of attributes that we're looking at. And a question came from one of the participants about measuring empathy. And do you measure empathy? And if so, does it change over time? And they were specifically asking about graduate medical students. So it's interesting. Most of the people here at Select International are psychologists, as folks that build these tools. And one of the things they'll tell you is we are measuring traits here that are fairly stable. So I score low in attention to detail. I always will. That's not going to change. Empathy is the same. If someone scores higher or lower in empathy, that's going to tend to be consistent over time. So that's not going to change. But there's two things. One, we don't measure it frequently with physicians. We have some clients that ask us to measure it. We have some clients who have decided that a certain level of empathy is going to be, we're going to assume that it's there with the physician. We have had situations where it's asked and they asked us to measure it. Sometimes it's not empathy towards a patient because physicians are sometimes offended that we would ever measure that, but empathy towards colleagues, empathy towards when they're working with administration, but these are generally stable. There is some interesting research, though, that some of you may have seen, that when they look at medical residents, that certain measures of empathy actually worsen over time. In other words, during their training, we drive empathy out of these folks. So that's some interesting research, but generally speaking, these things are going to be particularly stable. The other thing that we talked about was physician leadership, and I wanted to ask Mike what UPMC is doing to identify and develop physician leaders. And I know we've done some work with UPMC's Leadership Development Intensive, for instance, a very nice 12-month program and physicians are involved in it. But within physician services, Mike, what's UPMC doing to identify physicians that have leadership potential and developing that?
Well, Brian, this is another focus area for us, and I think in healthcare, the same rules apply, right? The best nurse doesn't always make the best nursing leader, and we find the same thing with physicians. The best physician doesn't always make the best physician leaders, but we can try our best to really, shape some of those physicians. So you mentioned our leadership development intensive, and that's a program for operational leaders, but we're really starting to have similar programs for our physicians. And, ideally, since we are so big and we do work so hard to recruit physicians and also train our own physicians, we've really been focusing on strategic succession planning for all of our departments and sitting down with our chairs for the first time over the past couple of years and understanding, who are all their chiefs on the academic side and who are their vice president of medical affairs and medical directors within the hospitals, and even working with our primary care groups that have their own leaders in understanding who are these people, how close are they to either retiring or leaving that appointment or maybe leaving UPMC for new challenges in the future, and then trying to have lists of individuals that are within UPMC that hopefully diverse lists of individuals within UPMC that we can really start to target for future dates when some of these physician leadership openings will occur. And, I think once we understand these individuals, we can really put together specific development programs for them with stretch assignments and exposure to some of our executives. And we have a lot of executive coaches that we use. We have a handful of them, and I'm very close with a number of them because we use them so much. And then we also have a partnership with University of Pittsburgh, which is sort of our sister institution. We have a physician leadership program that's named after one of our former prominent physicians that each summer we have about a 12-week program, and we call it a mini MBA. And that mini MBA is, it's really a mix of both behavioral type training, so performance management and coaching and change management and interview skills and some of the burnout work that we're talking about or wellness work that we're talking about. But then some of that practical business acumen work that, Brian, I think you alluded to a little bit before. And we don't need to teach people, finance 101 or advanced finance or advanced HR or legal work, but we certainly do have sessions that for example, I partner for a human resource session with a professor at the university. We have people that, from finance that do the same. So it's really a partnership between us and these professors to teach some of the practical business skills of, you don't need to know all of finance, but you need to know how UPMC views finance or UPMC views human resources and maybe some basics in performance management and labor laws and things of that nature. So it really is a nice program if we can plan. However, sometimes you can't plan, and when we bring new physician leaders in, any new physician leader that has a new direct report, we enroll them into a program as well. And it's a program over the course of a year where you actually go through with a cohort of other new physician leaders. So it may be quarterly, and you develop relationships with other physicians throughout the organization that you can. It has the effect that you can pick up the phone and call them and just say, hey, this is a new experience for me. Have you experienced this before? What's your best practice on this particular topic? And it helps them start to develop some of those leadership bonds and relationships throughout the organization. And then we also just have random offerings for training development for physicians that may self-select. So because we don't necessarily select a physician for leadership doesn't mean that we're not willing to provide leadership development for them. And, we have outside speakers and inside offerings as well where people can sign up for those. So that's really what our focus is right now, Brian, on physician leadership development. We want to continue to refine that, but I think we're off to a good start.
And every organization is sort of in the same spot. I think you guys are a little more advanced because you have a lot of resources, but the idea is we need really sound physician leaders, and I have found that physicians who have access to these resources are incredibly grateful for them because they pretty much come out of residency with being expected to be a leader in some way, shape, or form, but they've had no training, no tools, no resources. So we've had clients for instance, do a project where they'll say, we've got a group of physicians that we think have some leadership potential. So as part of some training, they'll do a physician 360 where they get feedback from colleagues, just like we would in any other area. And then we would actually use, I think I showed you the select assessment for physician leaders, which again measures 18 leadership competencies. Out of this, I can look at someone like Barbara as a potential physician leader. Between this and the 360 and whatever performance data I have, maybe she served on committees, I can really start to identify someone's potential as a leader. And then if there are structured programs to plug them in, that's great. If they need mentoring, if they need individual development, that's good. We did get a question that's sort of a core question about behavioral assessments, and it's a legitimate question, is the idea that physicians are relatively bright. If they're taking an assessment like this, particularly during the hiring process, are they going to provide the socially desirable answer? And of course they are. And the nice thing about working with the group that we have is, if you have a really well-designed personality or behavioral assessment for hiring, it has that understanding built into it. So it's built with the idea that this person is motivated to skew all their responses towards the socially desirable answer. So you're not taking something as simple as the Myers-Briggs or some of the other tools that are out there that have uses, but they're short, they're simple. This is a little more sophisticated tool. Again, these are the tools that a GE or Goodyear or Toyota might be using to choose someone at a leadership level. So the tools have that built into it, so we understand that.
Brian, if you don't mind, I'll jump in. I mean, yeah. You and I worked on, when we opened a hospital that we built in the eastern suburbs of Pittsburgh. This wasn't necessarily for physicians, but generally any leadership role took the assessment for leaders. It took about an hour and a half. It takes about an hour and a half. And if you try to fool it, you're going to do very, very poorly on that assessment, and the same for the staff level and clinical level assessments. But I think, certainly these assessments are very, very good for hiring decisions and pointing you in the right direction when you're going to explore during the interview process. But the one thing that we did for every manager, director, vice president, et cetera, that was hired for that particular hospital is to take the samples on the screen, that it was similar to this type of sample, and really then try to map each of those areas over to a specific offering of training and development within our organization, so that, my thinking style, I may have some issues with open to my flexibility with new ideas and managing change, right? So I could almost like a physician prescribe, well, in the next 3 months, I want you to sign up for change management here, and here are the offerings for them. So as much as we used it for selection, we also used it for very individualized development plans for those managers, because everybody's not going to be a 10 in every category, and you just need to work over time to develop some of those skills. So I thought it was a great way for individualized training development plans.
Oh, there's no doubt, and I can tell you, if you're starting down this path with physicians, it's much easier to start it as a developmental initiative, because it's about training, it's about performance. But I think Barbara and her group and some other clients, we found that a slightly different approach with a shorter assessment can provide some value even in the hiring process, which is great. And we're going to run out of time here, so I'm going to ask one final question, which is really practical, that somebody asked. And I'll ask Barbara first, and then Mike, I think you're familiar enough with the group. What are you doing with advanced practice providers, Barbara? Is the process similar? Does the physician group at Baycare Medical Group handle the hiring of advanced practice providers? Does that go through HR at the system? How do you handle those? Because to Mike's point, everybody's adding more of those. So what are your thoughts on making sure that you build a really strong advanced practice provider program?
Yeah, that's again a very relevant point. Yes, we're a hybrid because TR is involved in the hiring process in terms of establishing the salaries, but our physician recruiters treat the ACPs or APPs very similar during the interviewing and recruitment process that they do with physicians. We had not yet rolled out the assessment to the APPs, but we're about to, in particular because we're finding there's a lot more turnover going on. And again, our process has been, okay, if the physician likes them, we give them an offer, and there is not much depth to it. So now that we've seen the success on the physician side, it's well worth rolling it out to the APP side.
And I've also seen, to the concept earlier of operational fit, I've done some work with advanced practice providers and physicians, trying to make sure that you find a good fit and match there, because I've found that physicians will only use a PA or a nurse practitioner how they've been trained to use them, and that might not be consistent with the way Mike's group envisions the use so that we get the greatest utility. So when you're bringing the advanced practice provider in, it's nice to understand how the physician intends to use them, so that you can make sure that that APP is in a role that they're going to feel valued. You know, they don't want to be a scribe, and if that's what the physician has used a PA before in the past, that's probably what's going to happen. Mike, do the APPs come through your group, or do they come through HR generally?
The APPs actually go through our staff hiring process. So for APPs, we consider our APPs the CRNAs and anesthesia, our physician assistants and nurse practitioners, our neonatal nurse practitioners, and the midwives. Every staff member, so essentially everybody but physicians, goes through an online assessment. We do use some assessments for physicians, but every staff member at UPMC, and we hire somewhere around, I think, 25,000 employees a year, goes through the assessment process. So we use them for all APPs. And you're actually right, Brian. Something that's very important for APPs, as everybody on the phone probably knows, is they want to work towards the top of their license. They don't want to be a medical assistant or a nurse or a scribe, and you know, fit between a physician leader or a physician that's going to provide leadership to an advanced practice provider is it's a very important relationship, and we have to get it right. Otherwise, it just doesn't work, and that's where you see a lot of turnover.
We are running exactly on schedule. So what I'm going to do is tell the group, the attendees, there were a long list of questions that we didn't get to. We will send you a note. Once we get through the summary and Becker's provides all that information, we'll send a note out to either just respond to these via email, or if you want to talk about something, we'll make arrangements to do that. I wanted to thank Mike Anderson, particularly since Mike jumped into this project really late. Essentially last week, I ran into Mike and asked him to join the call, so he didn't have much time to prep. Barbara and her team, I know she's got Kathy Lee there, who runs the recruiting functions at Baycare Medical Group. I want to thank those guys because, again, everybody's busy and they want to take some time out of their day to share their concepts and ideas. So I appreciate everybody joining us, and I'll hand things back to the folks at Becker's and hope everybody has a great day. Thanks.
Thanks, Brian.
Thanks.